Yeah, good morning. Thanks everybody for being here. It's a pleasure. I work at University Medical Center with Dr. Bowman, Dr. Walvikar, a lot of co-work with Dr. Freelander as well, and then I was a resident, worked with Dr. Wong, so it's a pleasure to be here. I'll be talking a little bit about surgical management of these head and neck cases. So just an overview, we'll be talking about the different subsites that are treated, and I'll try to go through that quickly since we've gone through a little bit of that. The role of sentinel lymph node biopsy in head and neck cancer, transoral robotic surgery, just kind of reiterate some of the points that Dr. Wong brought up, and then large ablations and flea flap reconstructions, which I think Dr. Bowman and I need to share slides one day to make a big talk on these together. So the part I love about my job is in head and neck cancer, we get a lot of different subsites that we get to treat. We're treating skin, oral cavity, oral pharynx, larynx, salivary, endocrine, sinonasal, and skull base. So these are a variety of patients you see in the clinic that you get to see and treat, all with different tumors and different managements. When you break down our cancer types that are treated based on subsite, there's a big variety of differences. A lot of our tumors are squamous cell carcinoma, but you can see there's plenty more within each subsite, and many more than that are listed on this slide. Treatment of head and neck cancer, as we all know now from all these talks, can be complicated. It can be surgery, radiation, chemotherapy, or a combination of the three. To Dr. Bowman's point, I agree, multidisciplinary tumor boards are a really big part of the treatment management decisions and includes a really large group of people that are all giving their input and insight into how to best treat each patient with each situation. When we look at treatment for oral cavity cancer, Dr. Wong kind of reviewed this earlier, but surgery is definitely the standard of care when possible. We save radiation and chemotherapy for advanced cases or cases that have perineural invasion, positive margins, lymph node involvement, or extranodal tumor extent. But there's been a lot of studies that show that upfront surgery is the best treatment, especially in early stage compared to radiation. I wanted to talk a little bit about sentinel lymph node biopsy, and that seemed like the best place to fit it in. For those who aren't aware, this is when you use a radioactive dye to inject around your tumor to help identify the first few lymph nodes that the tumor is draining to. We can look at imaging to identify where these lymph nodes are and use a probe intraoperatively to remove these lymph nodes, and have them evaluated by our pathology colleagues to see if there's been tumor spread. Sentinel lymph node biopsy is really important in terms of prognosis and can help guide subsequent treatment, whether we can manage with monitoring the neck dissection or proceeding with a neck dissection or giving chemotherapy or immunotherapy treatments. In head and neck, we use sentinel lymph node biopsy in melanomas, diseases that are greater than 0.8 millimeters or some that are less than that with adverse features. It can be used in oral cavities, squamous cell carcinoma with small lesions, T1 and T2, and 0 lesions, but it can be difficult with the shine down effect. When you inject this area with a radioactive tracer and then you try to identify, it can be sometimes really hard to get these nodes because of the shine down of the original injection, and so it's something that is a little bit technically difficult. You can also use sentinel lymph node biopsy for Merkel cell carcinoma and consider it with sebaceous carcinomas. This is a patient of mine who had a Merkel cell, you can see here just under the eye. He went to our colleagues to have the injection of the radioactive iodine. Here's the imaging that we get post-injection and pre-surgery, which is all done on the same day. You can see here, which is where the tumor was injected, it lights up pretty brightly. And then on the scan, it helps us kind of identify here within his parotid bed, he's got 3 nodes. Given this information, it helps me kind of rediscuss with the patient before surgery what the plan will be and exactly where I'll be trying to look for these nodes, and helps guide me for when we're making our dissection. So intraoperatively, we remove the main tumor specimen first and clear those margins. And then we knew that we were going to need some advancement of this gentleman's cheek tissue to close, so it was nice for me to be able to open up this wound, identify the whole parotid bed, find those 3 lymph nodes to send to pathology, and then close his wound nicely. Thankfully, all of his nodes were negative, so he didn't require any further dissection, but it was nice to be able to have that done and get a good examination on him. Treatment of oropharyngeal cancer is typically treated with chemotherapy and radiation. We've been shown that people have good treatment responses, and there's many trials looking at de-escalation with P16 cases. And so what is the role of TORS in these situations? TORS was first approved in 2010 by the FDA to use in head and neck cancer patients. And then our largest randomized control study examining TORS for patients with intermediate risk P16 cancer and de-intensified treatment was done with the ECOG 3311 trial in 2013. I think when to use TORS is the biggest question and decision point that I work with talking to my residents about. I think the appropriate use of TORS is when surgery or doing TORS is going to reduce the need for the dose of or bilaterally of radiation and chemotherapy. You also want to make sure that the surgery is going to have a limited morbidity. These patients can have a lot of postoperative pain or swallowing issues, and so I think taking each patient selection into consideration is really important. When we're looking at our NCCN guidelines, you can see here for early stage P16 positive cancers, TORS is an option versus definitive radiation therapy. But this is what I'm always pointing out to my patient or my residents before tumor board discussions. If one of these patients goes through surgery and has any of these adverse features, which are going to be listed here, extranodal extension, a close margin, a positive margin, or more than one positive node, they're going to then be put into this, what Dr. Wong called the strikeout mode. They're here where they're going to get that triple modality therapy, and I don't think we're saving patients in terms of toxicity and morbidity in the end. And so having a really good discussion in your tumor board and making sure that you're looking at these patients and their candidacy is important. Just because we have the tool in the toolbox doesn't mean we should always use it. Contraindications for TORS, just from a surgeon standpoint, you don't want to use TORS when your planned margins are close to large blood vessels. This is kind of what our view is intraoperatively. So the patient is laying down, the tongue is up here, and they're on their back, so you're looking at their soft palate here. You can see if you're going to remove a tonsil tumor with a margin around it, you're right near the internal carotid artery, and some people, the base of tongue, you have the lingual arteries. And so those are things you need to account for when you're looking at these patients to see if they're a good candidate. Midline tumors, you shouldn't be doing TORS on. You can have risk to both lingual arteries. And then anytime your tumor resection is going to require a large gap, more than 50% of your deep tongue musculature, more than 50% of your tongue base, or 50% of your posterior pharyngeal wall, these patients are going to have really significant side effects and trouble with their swallowing, that this is probably not the best modality. So again, always advocating for TORS when it's the right situation, but only when it's going to decrease the need for further therapy. Larynx cancer, I think, is one of the ones that in tumor board is often a discussion on a patient-by-patient basis. Early stage cancers can be treated with radiation primarily or transoral laser microsurgery. And then the T3s are the ones that kind of border. I think surgery is great, but in patients who can save their organ, they're swallowing okay, they're speaking okay, and they're breathing without a tracheostomy, you can talk about definitive chemoradiation with them. And then T4s, we're usually pushing for that surgery because of the fact that we know with the VA study that their outcomes will be less. I want to just then go through some of the complex reconstructions of head and neck cancer and the defects. These are the patients that we're seeing and trying to decide what the heck to do, how to fix this gap, and then explain a little bit about the work that I do with the free flap reconstruction. So this is a patient of mine from fellowship. She had a large oral cavity cancer that had obviously eroded through her mandible and through her skin. And so when you go through and take out all the margins, this is the defect that we're kind of left with in surgery. And so here you can see this is the cut portion of her mandible that's now missing from here. She is keeping her native tongue, and then a lot of soft tissue is gone from the tumor itself and neck dissection. So when you walk into a room and you have this as your defect, you have to have a good plan for how you're going to fix this. This isn't something you can just close primarily, and you have to keep in mind, like Dr. Waldkar talked about earlier, these patients, your goal is to get them to be able to speak, swallow, and get around in town without looking too different. So this is what free flaps come in. What is a free flap? It's a piece of tissue that's disconnected from the arterial and venous blood supply. It's moved to a different part of the body and reconnected in order to help keep it reperfusing and then reconstruct a wound. It's fairly high on our complex, in terms of complexity on our reconstruction ladder, knowing that it's right up here. And when I explain it to patients, I explain it that they're kind of transplanting from themselves to themselves again. I'm going to take tissue from somewhere that they don't need it and recreate whatever hole they have to try to make them functional. In order for a free flap to be successful, the flap needs good blood inflow from the artery and good outflow from a venous system. And so we're harvesting both the artery and vein with whatever tissue we're taking in order to be able to connect that and keep it going. But problems on either side of the artery or vein can be catastrophic. If you get a clot or poor drainage, the flap will die, and then you're left again with a big wound. So going back to this patient with her tumor, her defects, we plan to do reconstruction using part of the latissimus muscle, part of the skin from her back, and bone from her scapula. So you can see here, just to orient everybody, this is the skin from the tissue on the back with the underlying latissimus muscle. the artery and vein that's going up to what we call the pedicle, and then the branches of the artery and vein that are going to this lateral border of the scapula. We can then contour that bone of the scapula to fit a pre-designed plate, and then this is going to be used for the soft tissue coverage of her. So post-operatively, obviously not perfect, not how she was born, not how it looked before, but I think much more functional and less to manage compared to a draining chronic wound. You can take free flaps from numerous donor sites, arms, legs, abdomen, and back, and then you can use different parts of the body, whether it's just skin and fascia or you're including muscle or bone, and that's really decided on what you need in each case. The vessels of the area are going to be divided, and then you're going to re-anastomose them at the recipient site. And again, clots or infection can really be catastrophic to the wound. These are just pictures of us. We use the microscope to suture the artery to the new artery in the neck somewhere using some really fine suture, and then the vein coupler device to keep that system flowing. Common free flaps that we use are from the thigh, the arm, the back, the fibula, scapula, and the gracilis. These are all just pictures of kind of where we can take from. And then our plastic surgery colleagues usually do a lot of these from the abdomen as well for breast reconstruction and other wound. I think from the, I just putting this up here to kind of show the ALT or the lateral thigh free flap. We're using the skin from the thigh. We're taking the vessels and the perforators to the skin off the lateral femoral circumflex artery, and then that's what's going to be transplanted. This is another patient of mine, and I believe Dr. Bolmes as well. She had a large squamous cell carcinoma of the skin. She has albinism, so she has many, many skin cancers, but this was a large one that was over her parotid. I don't have any intraoperative photos of her, but she had a big resection, a parotidectomy, and neck dissection, and then we were able to use tissue from her thigh to kind of reconstruct that wound. This is her post-op, and since then she's made me go through and make it even less fat, and it's a little bit smaller, and so she's continuing to do well and heal from there. This gentleman had an orbital squamous cell carcinoma that Dr. Walvikar and I did together. He unfortunately lost his eye in his surgery, which was non-functional, but again, using that ALT or that thigh tissue to reconstruct his wound has let him to go on and carry on his life out in the Baton Rouge area. The radial forearm free flap is often used for things in the oral cavity just because it's a nice, thin, pliable tissue. You can see here kind of how the harvest is designed, taking some of this skin paddle. We take the artery and vein up to the level of the elbow, and then you can transplant it. And this is a patient who had a hemiglossectomy defect, this being her native tongue and this being the forearm reconstruction. And again, just another example of one that's being shaped differently just to contour to the underside of the tongue and the floor of mouth with the bilobed portion, so that patient can still put their tongue out, but also close that floor of mouth wound where their tumor was. The latissimus dorsi was one that I showed in the earlier one, but this is a gentleman who had a large basal cell carcinoma that involved his calvarium. He underwent a huge resection with our neurosurgical colleagues who had to take a lot of bone and dura. They reconstructed with this plate, and then we were able to use the latissimus and skin from his back to help for his reconstruction. So this isn't exactly him. You can tell the people are different, but I just wanted to use this picture to show the latissimus muscle is a nice, very large, thin, pliable muscle, and you can take a variant amount of skin on it if you need to. And so then for him, another functional reconstruction. The latissimus can also be used a lot for our pharyngeal reconstruction in patients who have a pharyngectomy with their laryngectomy. We need to recreate a swallowing conduit from the base of tongue to the esophagus. And so using the latissimus, you can make this nice tube, which has a really large diameter for the patients to then have swallow later on with good soft tissue coverage, because oftentimes these patients may have been radiated prior and have a lot of post-radiation fibrosis or scarring of the skin. And then the fibula is kind of our workhorse bone flap. You can take just bone, you can take bone and skin. You want to make sure your patient is somebody who's got good runoff to the foot, so they have good vascularity of their foot after surgery. And everyone's always worried about taking the fibula, but it's actually not a weight-bearing bone. So these patients go post-op day 1, they can start walking and ambulating with just a walking boot on that we leave for about 6 weeks. We do a lot of virtual surgical planning, and I liked this picture just because the person that was playing with me hadn't taken the foot off, but we use their specific scans from their leg and their mouth, their tumor, but it just kind of, people are always like, you're going to put my leg in your mouth? I'm like, yep, it's going to look just like that. But some pictures intraoperatively, and this is kind of what the virtual surgical planning is like when we do it with our colleagues. They have the imaging showing the tumor. Then they'll take out the tumor with our planned resection margins and show us our defect, and then we can use the software to figure out exactly how long or how many segments of bone we want to use off of their fibula to reconstruct and get them back to kind of their native projection and contour. This is a patient of ours from here in New Orleans. Again, another large oral cavity cancer eroding through the skin. He underwent a large reconstruction and required 2 free flaps. So this is his fibula bone that's reconstructed here with a plate, and then this is his skin from his thigh that was going to reconstruct that soft tissue defect that he has. This is just showing another picture of that. And then this is post-operatively. This is the skin from his fibula, the lateral part of his fibula, covering the bone. And then this is that thigh tissue covering from the outside, giving him something functional. He's been doing great. I actually saw him last week. We're doing some touch-ups for some bone exposure right here at the chin. But otherwise, he's home and back to fishing. So in conclusion, treatment of head and neck cancer takes a team. Tumor board discussions are critical for the treatment decisions and managing each patient. And while many subsites are treated surgically, we definitely rely on the adjuvant treatments to improve our patient survival outcomes. And then just complex wounds take pretty complex reconstructions, but and many, many resources. And so I'm very thankful for all the people that we have at university that helped me make that possible. And that's it. Thank you.